not so simple. It is a quite difficult topic to discuss, and it is quite a controversial topic, and it's highly debatable topic, and it has been very less studied so far. So it is very difficult to discuss, sum up, and conclude this topic. But in this time, this is, as we have seen many cardiac eventuality or fatalities in asymptomatic patients, in asymptomatic apparently healthy persons. So this is the hot topic to discuss these days, and this session should stimulate us to formulate guidelines for screening or evaluate asymptomatic persons, especially in Indian persons. So there are many inherent or inevitable queries with this issue. Why the need to discuss asymptomatic person, and which are the person who should be evaluated for the coronary artery disease, and when they should be evaluated, and if we plan to evaluate them, what tests should be done and how they should be followed up. Most of the literature on the asymptomatic patients on the coronary artery disease has been for risk stratification of coronary artery disease, but not for the management point of issue. But if something comes up, very high risk situation on risk stratification, or management issues come into place. So rationale for this topic comes from that most of the acute coronary syndrome are in prior asymptomatic cases, and most of the individual lack acute, in most of the individual person, we cannot accurately estimate cardiovascular risk. And with this current therapy, disease modification is possible. And if we, as a cardiologist or as patients know their coronary status, it can be reassuring, but sometimes it can be opposite also. In India, as the cardiovascular disease burden is enormous, and more younger patients are at risk, and there is severe lack of acute care should the need arises in this patient. And for Indian patient, we have not developed any cardiovascular risk assessment tool, and whatever we have, they are not applicable to Indian population. And most of the guidelines have few words or few lines about asymptomatic patient screening for cardiovascular diseases, and leaves a big question mark on this issue. In European Society says that more than 40 years of patients, more than 40 years of subject should be screened for cardiovascular risk for the future event, and they have suggested that coronary artery calcium, carotid ultrasound, ankle brachial index, and should be maybe reasonable to risk for the risk enhancer, and in high risk patient functional assay or coronary angiography, in non-invasive coronary angiography may be considered for high risk cases, and exercise ECG may be considered for risk asymptomatic patients. But carotid intima-medial thickness measurement in low risk patients functional and CT coronary angiography is not recommended. American cardiology says that flow medial dilatation, arterial stiffness, CT coronary angiography, and CMR angiography, stress echocardiography, and stress MPI in low risk patients, and coronary artery calcium scoring in low risk patients is not recommended, and CIMT and ankle brachial index is class 2A indication, and coronary calcium scoring in intermediate risk is class 2A indication, and in low to intermediate cases, it's class 2B indication. And in high-risk patients, stress MPI is a class 2A indication. ACC guidelines says that 40 to 75 year of age person should be evaluated for the cardiovascular risk assessment, and coronary artery calcium can be used in intermediate to borderline cases as a risk enhancer, or to modify the risk of the cardiovascular event in future. So besides conventional risk factors and risk enhancer factors, many other novel risk has been added or being added in various guidelines, and even such as that even a person with migraine is at high risk for cardiovascular event. So these factors should be considered, should be taken into account for considering cardiovascular risk assessment. Some says that if you have assessed per person for the cardiovascular risk, a global cardiovascular assessment has been done for some, if you have done, then in low risk patient based on no further testing is needed. And for intermediate risk of patients, then they should be undergo non-invasive testing for further risk assessment. And in high risk cases, no further testing is required, and they should go for high intervention, high risk factor intervention. If we decide to go for non-invasive test, which test should be done? Whether it should be anatomic or functional imaging or hybrid, it's not clear, especially in asymptomatic coronary artery disease. And of course, molecular imaging and nanoparticle imaging are in investigational still. They are not used. So appropriateness criteria for each non-invasive testing, if you see that exercise testing, there's no class 1 indication. It should be considered in patients evaluating with multiple risk factors and asymptomatic men more than 40 years and women more than 50 years who plan to start vigorous exercise, who are involved in occupations in which impairment might impact public safety, and who are at high risk for CAD for other diseases. And in class 3 indication, routine screening for asymptomatic men and women is not indicated. Regarding role of appropriateness criteria of coronary artery calcium scoring and coronary artery angiography, in case of family history of premature coronary heart disease and low global risk, ACC, American College of Cardiology says that it is appropriate to go for coronary calcium scoring, but asymptomatic patient, no coronary artery disease, low risk patient, it is not appropriate. Intermediate risk patients, it is appropriate. In high risk patient, it may be considered or it is may be appropriate. Regarding coronary CT angiography, in asymptomatic, no coronary artery disease patient, in low risk patient, it is not appropriate. In low risk cases, it is not appropriate. In intermediate risk, it is not appropriate. In high risk cases, according to American College of Cardiology, it may be appropriate or rather inappropriate. But according to Asian Society of Cardiovascular Imaging, in asymptomatic, no CT angiography may be appropriate. And in a recent review, that CCTA in asymptomatic person to determine presence of subclinic atherosclerosis may be useful as an alternative to coronary artery calcium scoring in certain settings like young person, familial hypercholesterolemia and diabetes. CT along with FFR is useful test and it's important, but we do not have this facility in India. If we see that if the CT FFR has is found better than other imaging modality in significant ischemia. Stress MPI in low risk patient is not indicated. In intermediate risk patients, it is inappropriate when ECG is interpretable or maybe uncertain in some cases. In high risk cases, it is appropriate. And it is also appropriate in if we have done calcium scoring and high risk patient in calcium scoring more than 100 or to 400 or calcium scoring is more than 400. And regarding PET MPI in asymptomatic patient, it is appropriate only in patients who have high pretest cardiovascular risk scoring with a calcium score of 400 to 1000. Asymptomatic patients who have calcium score of more than 1000. Asymptomatic patients with equivocal and abnormal prior test result from CCT or invasive coronary angiography. It is rarely appropriate in asymptomatic patients with low risk score, asymptomatic patients with intermediate risk who have interpretable ECG, and asymptomatic patients with a family history of premature coronary artery disease. It may be appropriate in some asymptomatic patients with intermediate test global risk assessment who have uninterpretable ECG or who are unable to exercise. asymptomatic patients with high pretest probability of CAD, asymptomatic patients with intermediate pretest probability who have calcium score of 400 to 1000, and asymptomatic patients with peripheral vascular disease, familial hyperlipidemia, and asymptomatic patients with recent less than equivocal or abnormal test results from the stress testing, whether it is imaging or non-imaging. Regarding use of cardiac MR in coronary artery disease or in asymptomatic patient, in low risk patient, moderate risk patient, and high risk patient is not recommended. And regarding coronary MR angiography in low risk patient, in moderate risk patient, in high risk patient, it is not indicated. Coronary CT angiography, if we see compared to other non-invasive modality, has highest probability of detecting significant coronary artery disease as compared to other non-invasive tools. Of course, artificial intelligence has come up into in many areas of cardiovascular diagnostics. So according to artificial intelligence-based risk assessment, if patient is very low risk, no further evaluation is needed. If patient low risk, medium risk, high risk patient, non-invasive evaluation may be indicated. In very high risk cases, invasive evaluation is indicated. So again, coming to CT and non-invasive coronary CT and FFR, if both are available, then we get so many information about coronary, like such as coronary atherosclerotic burden, calcium, coronary anomalies, positive remodeling, inflammation, plaque characteristic, ectasia, and perivascular fat, and cardiac perfusion also. So if we know, if we plan revascularization for any patient, and if we know all these things, then it helps in strategy of revascularization. So FFR CT is in my opinion, in current era, it should be considered in patients who have intermediate or high risk scoring on the global risk assessment tools. So this is the test which is, can be taken as one stop for all. I thank you all for listening.